Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. When I was training, rheumatoid arthritis was a chronic and incurable condition, with many patients experiencing a lifetime of complications and chronic comorbidities related to their illness. Indeed, when I graduated fellowship in a very famous Georgetown ceremony, we had a ceremony that involved the DC Queen of Rheumatology, Dr. Gail Carr, with a sword, and all the graduating fellows had to pledge they would never taper patients off of therapy. But with the advent of targeted therapy for RA, times have changed, and remission is now commonplace, which leaves rheumatologists with the unanswered question, when can we safely wean remission maintenance therapy for patients with RA? The manuscript we will discuss today is Predicting Flare in Patients with Rheumatoid Arthritis in Biologic-Induced Remission on Tapering and on Stable Therapy. It was published in ACR Open Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I'm delighted to be joined by the senior author and previous president of EULAR, Professor Paul Emery. Professor Emery is head of the academic unit of the musculoskeletal disease and lead clinician of rheumatology at the Leeds Teaching Hospital NHS Trust. He was director of the Leeds Biomedical Research Centre, one of 20 centres throughout the UK supported by the National Institute of Healthcare and Research. And Professor Emery is well known for introducing early intervention in rheumatoid arthritis and bringing musculoskeletal MRI into clinical practice. Professor Emery was awarded the Carol Nashman Prize for Rheumatology in 2012, and he is listed as being the most cited rheumatologist in Europe. Welcome to the show, Paul.
Thank you very much, Vicky. Delighted to be here.
So I wondered if you could start by telling us the background of this study. As I mentioned, you have been a huge proponent over the years of early targeted therapy in rheumatoid arthritis. Why was it important to do this study?
Well, there's one thing virtually every patient asks you when they get rheumatoid arthritis, and then you get them better quickly, is how long do I have to go on with this therapy? It seems natural to us that you need continued therapy, but certainly not to patients who see their illness as something that we can treat and then stop with the therapy afterwards. So we've had a lot of patients for the last now 30 years who we've induced with early remission. And I thought it was our duty to try and find out which patients on an objective basis you could actually stop therapy in. And we did our very first study in 1995. It wasn't published for a few years, but that was inducing remission with infliximab and showed that you could actually stop the infliximab very successfully after a year of therapy. They were unusual patients because we treated them right at the very beginning after only a few weeks of disease. But we tried to make it applicable to a wider range of patients in this study. And this study was the culmination of many other bits of work, including work that looked at whether in a population of 600 patients in remission, whether if you took objective measures such as stringent clinical, imaging remission, and what we called immunological remission, if you overlapped those three, you are much more likely to have much better patient-reported outcomes. We thought that was probably the target we should be aiming for.
Yeah, and you recruited patients from the Leeds RA Remission Clinic. Now, this may be something that listeners in different healthcare systems are not familiar with, so I'm wondering if you could tell us a little bit more. In the manuscript, you talk about the requirements for entry to this clinic. It sounds a little bit like being a frequent flyer on an airline. What is the Remission Clinic, and what are the requirements for entry to the clinic and the benefits of being seen there?
It's interesting you should say frequent flyer, because we often say to the patients, you're going into business class now, which they have their own special clinic. And to get into it, you need to be in remission. We use just the conventional, and I know there's a lot of debate about how you define remission, but we just use conventional DAS remission for 6 months, and then they go into remission clinic. And they're followed there 3 monthly with more regular assessments that you don't do necessarily, which is ultrasound and immunological measures. So we have a 3-monthly update on how they are. So we have a lot of information on these patients, and they're suitable, if appropriate, for things like tapering.
And do they get a nicer waiting room and a cup of tea when they're waiting?
I wish the NHS could stretch that. It was when we first started it was nothing to do with tapering. It was what we called the Well Patient Clinic. That was 25 odd years ago. And what we tried to do then was to optimize other things like podiatry, cardiovascular risk, osteoporosis risk, rather taking your attention away from getting rid of inflammation, which we had hoped we'd done, and actually improving quality of life for patients.
Yeah. Okay. So addressing the comorbidities, that's a really good idea. So in your study, the patients were allowed to self-select either to taper therapy or to not taper therapy. So the patients, I think, weren't blinded, they weren't randomized, and similarly, the physicians treating them were not blinded. Why did you decide to design the study this way?
Well, you could criticize the fact it's not blinded and it's patient choice, but we deliberately went with that because, as you know, all our ULR guidelines are meant to be decisions made between the patient and the physician. And we felt that it was important we had volunteers for this. Also, because in previous studies, patients who have flared, who feel perhaps they had been in some way pressurized to go into the study, they felt very bad about a flare, particularly if they couldn't regain remission. So we felt it was probably best practice to do that, and it would be more widely applicable once it was published and perhaps the recommendation was adopted.
Yeah, no, and it definitely kind of mimics real life experience. So I think while there are pros and cons to every approach, I can totally see why you did this. So to clarify for our listeners, it was only the biologic therapy in these patients that was tapered, right? The patients in the study were receiving combination therapy, a biologic plus conventional synthetic DMARD, but only the biologic was being weaned. Is that correct?
That is correct. We have published an equivalent paper, which is about tapering conventional synthetic DMARDs, but those were in patients who were just on CS DMARDs. The argument, and it's something that we discussed at the plenary at the ACR last year, about which therapy in patients in combination you should actually taper. It's interesting. In Europe, we've concentrated on reducing the expensive therapy, biologic DMARD, whereas there's been a lot more interest in America in reducing the drug with perhaps greater side effects, which is methotrexate. And we perhaps come back to this because I think in Europe we've probably been wrong for some patients because it does appear that in late disease you can't really taper biologic DMARDs, whereas you possibly can early. And in late disease, probably you should be only tapering methotrexate, actually.
Yeah, no, I think those are really, really important questions. So tell us how these patients were monitored after the changes were made. How frequently were they seen in the clinic, and what outcomes did you look at?
Well, the procedures we used and the monitoring we used were for a research clinic, and I think adaptation later will change this. But we saw patients at least 3 monthly, or unless their clinical situation changed, in case we saw them immediately. And at a 3 monthly visit, they actually had ultrasound, they had T-cell biomarkers done, as well as all the usual clinical assessments and also quality of life assessments.
And so tell us a little bit about those T-cell variables, because these are not widely used in clinical practice, and you measured a number of different factors. Would you mind filling us in?
Yes, they're not complicated because most places during the HIV episodes we've had developed T-cell monitoring. But the things we measure are T regulatory cells, naive T cells, and something called inflammation-related cells. The regulatory T cells we found, and the naive T cells, we found extremely useful in all sorts of things in predicting the development of rheumatoid arthritis in patients who have an antibody, predicting response to methotrexate. And it's interesting, methotrexate works well when you've got normal Tregs and normal naive cells, but isn't able to improve the T regulatory situation if you're abnormal, whereas it has been shown, for example, with TNF inhibitors, that they can work when Treg cells are subnormal, and they do normalize them, which is a sort of explanation why methotrexate incomplete responders can respond to TNF. But we found that they are very helpful in predicting, and our hypothesis was that those who had normal Tregs, if you took away the biologic, they would be able to sustain their response with just methotrexate, which, as I said, doesn't change Treg levels.
Oh, well, that's really interesting, and can see that moving potentially into clinical practice. I always find it fascinating to know what gets developed for HIV and how we can adopt it in rheumatology. You know, we always think that we can't do these expensive tests, but it sounds like this is already in existence.
It is, we had a grant some years ago to make it a routine test, and we found it very useful in combination with other biomarkers. So it is a route that we can just order it like you would order a CRP.
Yeah, fantastic. Okay, so let's talk about Table 1, which shows the baseline characteristics of the two groups. Were there any demographic or clinical differences between the patients who self-selected to taper versus those who did not?
It's perhaps no surprise that those who chose not to taper had more pain and VAS abnormalities. In other words, they were more symptomatic. And I suppose if they were already symptomatic, they were probably less likely to want to actually reduce their therapy and perhaps themselves worse. And the other factor we have found is that patients who have gone into remission early, you can't see that from the table, but those who had remission induction and who have never really experienced long periods of chronic pain were also more prepared to taper. And that's probably a good thing, because actually early remission induction is probably a factor in it has been shown to be a factor in successful tapering as well.
Yeah, interesting. So it definitely kind of gives you an idea of who's going to be a good fit for this. So tell us a little bit about what you found. Were there differences in flare rates between the group that tapered therapy compared to those who held the course?
The basic finding was virtually identical to what so many other people and we ourselves have found previously. If you tapered, you had a greater chance of flaring. It was 37% versus 20%. But that was just the overall picture. It was when we looked at complex multidimensional remission that we found different things, which, if you're happy, I will explain a little bit about.
Yes, keep telling us more.
The flare was associated with lower Treg cells and a higher CRP, as predicted, also ESR, but with stepwise modeling, the things that came out were T regulatory cells, CRP, and inflammation-related cells. And inflammation-related cells and CRP are pretty well, have some correlation, although they were separate indicators here. But the majority came from CRP and Treg. So you could actually choose patients on the basis of if they had a normal CRP, then you could do the T regulatory cells. If you had normal Tregs, normal CRP, and normal inflammation-related cells, they were low risk. And in low-risk patients, 37 of those tapered and only 5 flared. And of the 5 that flared, all regained remission. And that was a lower flare rate than in those who had continued therapy. In the high-risk group, 26 had tapered, although we didn't know at the time until we looked at it later, and 18 of those flared, so 69% of high-risk flared. And of the ones that flared with high risk, there was a smaller chance, not all of them regained remission. So for the first time, high risk identified 2 things, a high risk of flaring and a greater risk of not regaining remission, which has major implications. Just as a general point, the majority of the patients who volunteered to study, 65%, were in low-risk group. The final thing that we did find was that in the continued therapy group who didn't taper, their total ultrasound power Doppler and their VAS pain score were predictive of a flare of the 20% that flared.
And so tell us more about that non-tapering group, because I do think that's kind of an interesting cohort, because you use that low and high risk modeling to look at prediction of flares in that group as well. Can you tell us a bit more about how that proved to be useful?
Well, and we have showed this a long time ago with ultrasound, that if you had significant ultrasound, that you had a higher risk of flaring even with continued therapy. And that was confirmed in this study. Just to say that if you look at just conventional synthetic DMARD remission, there are different factors that come into play. But in this combination therapy group, total PD and high pain score are perhaps indicators that you might want to keep a very close eye on these patients, because they do have a higher risk of flaring.
Yeah, and I think that's a really important take-home point that comes out to me from this manuscript, that these biomarkers and the inflammation seen on ultrasound are measured when the person is in remission and yet seem to be kind of predictors of what the immunome is going to do when you adjust therapy. I thought it was also interesting that in the patients who scored into that low-risk group, if you subsequently tapered therapy and they flared, they would still have a high probability of regaining remission on reintroduction of therapy, which I feel like is a very common question your patients ask. If I do this, what's my risk of flare? And will I respond again if I'm re-induced? So what's your take on what this means for patients? Should rheumatologists be using these prediction models in practice? And do you have any caveats?
Well, there are certainly caveats. We have confirmed this approach in our own study, but it needs to be confirmed elsewhere. But the general principle is, as you pointed out, absolutely crucial, because the one thing patients do not want to do is lose remission and not regain it. Now, I mentioned it earlier. You feel very guilty as a physician when you see a patient who was in remission, who you tapered and never regained it. I learned that lesson very early on, that you really can't look a patient in the eye again. And that's why I find some of the studies which have suddenly stopped therapy rather than tapering it, and we don't have a lot of information. And I've been involved in several studies where the regaining of remission has taken either a very long time or has not been achieved at all. So it is very important, I think, that you can be reasonably confident of patients. You can never be 100%, and we're talking about small numbers, which is one of the caveats here. But I think you want to be able to have a certain amount of confidence that they have a very high likelihood of regaining their previous state.
And it sounds like you as a clinician are pretty comfortable kind of with that counseling, being able to tell patients, those who are in that high-risk group, to not try weaning.
Yes, I think that's certainly true. We do the high-risk group. Patients who are very keen to wean, we still actually would let them in high risk, but we would be monitoring them very carefully. And the lessons that we've learned is don't change things more frequently than every 3 months, because that's about the lifetime of the circulating lymphocytes that are being influenced by our therapies. And it gives you the chance to see a minor flare rather than a widespread flare. And a minor flare is often much easier to treat. And just as an aside, when we debulk disease with remission induction, we find the flares of those patients are very easy to control with a small amount of steroids just for a very short period of time. We usually give them either an intra-articular injection or intramuscular injection. And the minor flares are much easier when you have a great bulk of synovitis.
Yeah, no, I think that's really good advice, and thank you for sharing that. So, Paul, I wanted to change direction a little bit. Your career has spanned almost 50 years. You obviously have worked throughout the world. When you look back on the beginning of your journey, did you ever think you'd be running a study investigating stopping therapy for rheumatoid arthritis?
Realistically, no. I was right at the very beginning, though. I was convinced that we could do miles better than we were. Just the response of steroids weren't as early as 1980. I set up an early arthritis clinic. The impact of steroids, or even non-steroidals, is so dramatic in those early diseases that it was, provided we could get a less toxic steroid, I thought we would make a tremendous difference. And of course, to a certain extent, the anti-cytokine therapies are targeted, steroid effects with much fewer side effects than steroids. So I thought we could do much better. I didn't know whether we could stop it, but at the same time as we've been working on stopping, we've been working on prevention. And it's the changes that occur with immunological remission occurring after clinical remission are the other way around to pre-disease, where you get immunological abnormalities, then clinical abnormalities. Mm-hmm. We've called it the palindrome of rheumatoid because it's sort of back to front, and you end up at the end of it the same as you were at the beginning. So certainly when I started, I had no idea. That's absolutely true. But I think more recently, we've had probably ambitions above what we've been able to achieve. And it's only recently, in the last 15 years, we've been able to actually achieve what we've been setting out to do, which is achieve remission and gradually taper.
But it does make actually a lot of scientific sense. The immune system is supposed to be dynamic, and it shouldn't be so surprising to us that you can modulate it and potentially revert it back to, quote, its baseline state, normal state.
Yeah, well, that would be the hope. What has been perhaps the conundrum is that you can get patients completely well again, but they still have their anti-CCP antibodies.
Mm-hmm.
And we have several patients who've got into long-term remission, some off no therapy. It's rare, it's only, and I'll say now, we generally get about 20% who can stay off all drug if you treat very aggressively early, and even some who will go into remission, particularly seronegatives, without quite so aggressive therapy. But they don't lose their autoantibody. They lose their rheumatoid factor much more readily, which is a reflection of inflammation.
Mm-hmm.
It can be there, and they don't get recurrence of disease necessarily. Small minority, though.
Yeah, and I'm assuming that the kind of next phase of all of this research will be looking at specific drug targets and kind of assessing how to taper therapy dependent on the drugs that patients have been exposed to.
Yes, we don't have any evidence for that. What we do have evidence for is that the period of inflammation that occurs, untreated inflammation, does seem to produce cells from rheumatoid which become increasingly abnormal. They get more difficult to treat and more side effects, which is why possibly cell-killing therapy, which includes B-cell depletion, mm-hmm. does work reasonably well late, because you're not dependent on the metabolite of a drug or just inhibiting the signaling pathway.
Yeah, so more to follow. I feel like this is a constantly evolving set of questions and clinical decisions that it will be changing as time goes by.
Indeed. I think it's a very exciting time to be in rheumatology, that we do have the access to drugs now at a fraction of the cost, certainly in the UK, that we once had. Yeah, it saddens me a little bit, but we are not still allowed to give first-line biologic, because we're now developing biomarkers of which patients won't respond to conventional synthetic drugs. And we've just completed a study where we've randomized patients according to their predictive value of methotrexate response, and actually targeted the ones who are going to do badly with early biologics. And we'll see if that actually changes opinion.
Yeah, no, and those questions are so important. And I wonder, your career has taken you all over the world, as I mentioned. You've practiced both in the UK and then also for a period of time in Australia. You were also president of EULAR. How have those different experiences changed your worldview, both as a rheumatologist looking after individual patients in your own clinic back home, but also as an academic rheumatologist trying to advance the science of rheumatology and these policy questions that you're raising?
Well, it's interesting that, patients differ genetically, and there are some peculiar racial differences in drug responses and phenotype. But on the whole, I'm been surprised by how consistent the approaches are around the world. And there was a thing we did, which was a targeted ultrasound initiative, which I was lucky enough to chair. And we went to over 40 countries and developed, it was about 150 ambassadors. And the principles that we developed in Europe were applicable all around the world. And I'm pleased to say many of those people become world leaders in their own imaging and management of rheumatoid. So I think it just reinforces that despite our poor understanding of the epidemiology of rheumatoid arthritis, there are quite a lot of consistencies worldwide. And certainly Australia isn't as diverse because it has a big European population.
Yeah, I think that's so true, and definitely was my experience as well, moving from the UK to the US healthcare system. People are more the same than different, and oftentimes the challenges I experienced were more kind of getting the right translation of what I wanted to do for the patient. It wasn't not knowing what to do, because the patients actually responded very similarly to the medications.
Well, we've done studies within different racial groups in the UK, looking at people from the Indian subcontinent and comparing them with white Caucasians as opposed to Asian Caucasians. And the surprising thing is there were quite a bit of difference in phenotype, but the disease burden was identical. And although the Indian patients had less erosive disease, they had much more impairment of function. And in fact, probably one of the messages, we should have been treating them much more aggressively because we were focusing on structure rather than on the patient. So slightly contradicting what I'm saying, that there are phenotypic differences, but I think the principles remain the same. And quality of life is a really important endpoint.
Yeah, and that what matters is the patient in front of you, right? That you're designing the right treatment, tailoring the right treatment for the patient that you're seeing.
Absolutely, yes.
And tell us, were there any mentors who shaped or influenced you on your journey through rheumatology?
I think probably the most influential, actually, was the person who encouraged me to go into rheumatology, which was Gabriel Pranay, who was one of the first scientists, really, to go into what was, at that time, really a rehabilitation specialty. And in fact, it was called the British Association of Rheumatology and Rehabilitation. But he applied scientific principles and really made me think about going back to first principles whenever you have a problem. And the great thing about rheumatology were that they had multiple questions and very few answers. So it was an open field in which to do that.
And you've also mentored many rheumatologists over the years. Do you have any tips on what makes a good mentoring relationship?
No, I've been lucky enough to train 30 plus professors and well over 100 registrars, and they all remain good friends. And I think that's the teamwork, I think, is the answer. And the other thing we always say is, academic life certainly isn't going to reward you with a lot of financial riches. So it's got to be good fun. And it makes life go very quickly when you're enjoying yourself, but it's actually a team approach and making it fun to work together. That's the only things I can think. And, maintaining high standards and putting the patient first always.
Yeah, I think this is really good advice, actually. So among your many accolades, including being the most cited rheumatologist in Europe, you have another unique honor. And I think you might be the only rheumatologist in the world in this club, because you were appointed both by Queen Elizabeth in 2018 to the Officer of the Order of the British Empire, which is an OBE, for services to rheumatology. And then also in last year's New Year's honours, King Charles appointed you as a Commander of the Order of the British Empire, or a CBE, also for services to rheumatology. Now, I must point out to our international audience that these honours are not given lightly. Some rheumatologists have received similar honours, but I think you're the only rheumatologist to have been honoured with an OBE from the Queen and a CBE from the King. Would you mind sharing with our listeners what it was like to receive those awards? Did you go to Buckingham Palace, and did the ceremony involve a sword?
Well, I'm certainly the only one, because the King's only just started giving out honours. He's only been king short while. Yes, it was unusual to get an OB and a CB. I'm not quite sure why, but it was very nice. What was nice is that medics who get awards usually get them for political acts rather than for services to their own specialty. So it was very nice to get it for services to rheumatology, which I greatly appreciated. But I must say, going to Buckingham Palace, yes, and meeting the Queen, I had no great expectations about meeting Queen Elizabeth. But I must say, I came away totally in admiration of her. Her mother had a hip replacement, the Queen mother, and although she's primed to a certain extent, she actually had a conversation with me, and we went on for. In fact, I stopped the conversation, but she was so interested in arthritis, whether you could actually prevent it, how you could get patients into remission, and so on. And she was asking such intelligent questions. My expectations were totally exceeded, and I came away thinking, that was only a few years before she died, and she'd been the number of people she meets and how to maintain that enthusiasm, because it was real, genuine enthusiasm of sort of looking you in the eye, and like many people who've said it before, she was a very special individual.
Yeah, no, it's amazing and so lovely to hear that not only you receive this for services to rheumatology, which very often do go overlooked. And so I'm always excited to see when that happens. And then to hear that you actually had a meaningful conversation about the work that you're doing is really heartwarming.
You know, because they take a picture every 10 seconds in this special insignia room. My conversation was more than twice as long as anybody else's. So it was clear she wasn't doing it just for going through the motions.
Oh, that's great to hear. Have you received yet your CBE, or is that yet to come?
I have received the warrant, and for practical reasons, I could have had it in May, but there was a lot of illness in the royal family at the time, and I will be having that in November.
Oh, excellent. Well, I hope it's a wonderful ceremony and that you have another great conversation about rheumatology.
Thank you.
Thank you, Paul, for sharing your work with us today and sharing some of your experiences from your services to the field of rheumatology. Today, my thanks actually go to your patients, particularly those who, after achieving that elusive goal of remission, were willing to wean their therapy so that rheumatologists around the world could learn how to do this safely. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.